Hi, everyone, and welcome back to Triple Track's podcast. My name is Jen Dorsey. I am the clinical director with Triple Track Smoking and Vaping Cessation.
And I'm Dr. George Kolodner, an addiction psychiatrist who is the medical director of Triple Track.
And Triple Track is an outpatient program that treats adults with nicotine use disorder using medical interventions, outpatient group, and individual therapy. And today, this week, we are going to talk about CBT as a really tried and true method of intervention for addiction. And George, you and I talked about coming up with this topic because it's been you've seen a lot of transformation over the years in terms of what was available, in terms of language and treatment interventions versus what's going on now. Can you say a little bit about that?
Sure. CBT stands for cognitive behavioral therapy. And what was so welcome about it was it gave us a professional language to talk to our patients about that was something that they could easily grasp and use to understand their experience. And there was no language like that in the addiction field until this began developing, first in the 1970s and 80s by Alan Marlatt, a psychologist at University of Washington in Seattle. And then later in the 1990s by Aaron Beck, who was the father of cognitive behavioral therapy, who had developed his notions about working with people with depression and anxiety, and then began to apply these notions to substance use disorders.
And as a result of that, you mentioned before when you and I were talking that the only language really available professionally was in this sort of psychoanalytic space, which was
Right.
really not accessible to patients.
Right, because psychoanalysis focuses on the unconscious, which is by definition out of awareness. And CBT focuses on the conscious mind, the more on the surface of the mind. And Aaron Beck was famous for responding to criticism that his work was too superficial by saying that there's more to the surface than meets the eye. And the advantage of the surface is that you can see it in front of you and talk about it. And in fact, as Beck indicated, there's a lot of meaning and power in just the fact that it's on the surface doesn't mean that it doesn't have a great impact.
Well, and I think it's probably true that the more that someone is able to address what is there and seeable on the surface means that the stuff underneath starts to become eventually more visible, like peeling the layers of an onion or getting to see more of that iceberg that's underneath.
Right. The analogy that I used is that in psychoanalytic thinking, the unconscious is below the surface, and insight involves diving down underneath the surface. I think with CBT, it's more like having blinders and having those blinders open up so the person can see more of what's around them. One of the things about addictive thinking is it narrows your view. And that's where the distortion comes in. It looks at the immediate present and not at the future.
Yeah, I mean, as human beings, we already have we already have those blinders on, right? We don't really can't see the future, what's going to happen, and oftentimes in the present, we have a hard time seeing what's going on from our own perspectives, right? So in those blinders, but when you add addiction on top of that, really narrows that field of vision and understanding.
Yeah, and maybe it makes it clearer to folks if we jump right into the relapse sequence and talk about how we use that to illustrate some of these issues.
Definitely. Before we do that, can you say a little bit? I think it might be helpful to hear how you created this. Where did this come from?
So we're about to share with you a diagram that we call the relapse sequence, which I created by working from the language of Alan Marlatt, who really, I think, initiated the term relapse prevention. And diagrams that Aaron Beck put into his group. I'm sorry, diagrams that Aaron Beck put into his book.
Mm-hmm.
And I took Beck's diagram and began showing it to patients, and they liked it, but they felt that there were some areas that weren't quite right in their experience. So I altered the diagram in ways that made it uh, a little bit more complex
Mm-hmm.
or accurate. And I also changed some of his language to language that was more compatible with the kind of words that we use in the addiction field.
I love this sequence that you're going to get to see. I think that that our audience is going to get to see, because I think that the part about patients giving feedback is just so important. And I know for me, having used this over and over and over and over again, both individually as well as in group settings, it really helps patients, including our patients at Triple Track, understand all that is happening before they pick up that first cigarette or vape or whatever the return to substance is. So it's really powerful.
Yeah, I think that's the key, is that we found that when people come in with a relapse, they would present it as an event that happened in the flicker of an eye.
Mm-hmm.
By orienting people to the diagram, they learn that this is not an event, it's a process with multiple steps. And by understanding the process, they can slow it down
Mm-hmm.
and intervene and interrupt the process before it gets to the point of actual use. That there are many steps in the relapse process before we get to the point of use.
Yeah, there's a saying in the rooms about, a return to drinking, that a relapse happens way before you pick up the first drink.
Exactly.
And that's what this reminds me of. And it's also such a great example that the stuff that AA has known for such a long time, you know, the psychotherapy world is sort of catching up to that and really professionalizing, obviously not just taking from AA, but really seeing how AA already had some incredibly sort of natural insight and understanding of how addiction recovery works.
And that's another advantage of the CBT language, unlike the psychoanalytic language, uh, which is in conflict with some of the ideas of AA and the other 12-step programs. CBT is completely compatible with it.
Mm-hmm.
So to be able to have people both be in 12-step programs and talk to professionals about CBT language, they're not caught in the middle of some theoretical disagreement.
Mm-hmm. Reminder, everyone, this is Triple Track Smoking and Vaping Cessation, a fully virtual program that helps people quit nicotine for good. You can learn more at our website, tripletrack.com. Yes, I think to kind of come back to what you said, I love that CBT really focuses on what's on the surface, what's really, we have easy access to, and I think that's so important. And then the parts work that we do really, I think, lowers the sea level, so you could start to see some of what's underneath, what motivates some of the decisions that we make. So very true. And George, so this is the relapse sequence that you created. Can you walk us through what we see here on the screen?
Yes, and I'd like to start with the second step there, the trigger, to say that triggers are so central to this whole process. What we mean by a trigger is either an external object or an internal experience that comes to be associated with the use of, in our case, of nicotine, but with any other substance. Initially, the trigger is neutral, but it is repeated association with the substance, it acquires psychological power. And everybody is aware that when you take a substance like nicotine or alcohol or opioids, that sets off a dopamine release. But what people often don't know is that the trigger sets off an even higher dopamine release than the substance itself. And that's what makes it so powerful. So we actually can, by visualizing the brain through scanning techniques, you can actually see the physiological representation of the trigger, and showing that to patients is also makes their it's very helpful to patients in understanding that what they experience is actually reflected in changes that you can see in the brain. Triggers are, as Jen mentioned, central to 12-step thinking. That you will hear warnings about being cautious about people, places, and things that were associated with use. And also you'll hear the acronym HALT, H-A-L-T, standing for be on guard when you're having a combination of being hungry, angry, lonely, and tired. Those are all triggers. And that's really where the relapse sequence usually begins. Someone has a trigger present itself to them. Now, I added a preliminary step, which I call setup, rationalization, and behavior.
Before we get to that, though, before we get to setup, rationalization, and behavior, can we spend a little bit more time on triggers? Because you said external triggers and internal triggers, and I think this is so important. I think so. Just to really tease these two apart, the first thing is having triggers or not having triggers does not make one more in recovery or less in recovery. So I often hear people say, how are things going? Oh, I'm doing well. I didn't have any triggers. Triggers do not define someone's recovery. It's not something we can control, right? As you said, it's a psychological association, a connection that's happened over time between our senses, our internal experiences, and the use of a substance. So, for example, as an ex-smoker, right, I was just the other day with my 7-year-old at a gas station, and somebody had clearly just been smoking and had put a cigarette out, but it was still slightly lit. And we're walking by, and he's going, "Oh, mommy, that smells so gross." And I was like, "Oh, that smells really good. That cigarette smells really good," right? So even though it's been a long time since I've smoked, right, it instantly, that smell brought me right back to, which of course we know is so powerful, and our scent. So as an external trigger, another thing might be seeing people smoking or vaping in front of me as an example of an external trigger. It may be for some of our vaping patients driving by gas stations or vape shops where they would stop to grab a vape. Those are usually, those people, places, and things are fairly easy to identify for our patients. The level below that are those internal triggers, which I think in some ways is defined by the rest of the sequence. But I wanted to make sure we talked a little bit more about that before we move on to the rest of the sequence.
Right, and I think at the risk of getting into too much detail, the people, places, and things are an example of what we call cue triggers.
Yes.
Those are the ones where learning has occurred, and they're very powerful, but they tend to disappear relatively early in the recovery process. We use the professional word extinction, that when you encounter a trigger and don't follow with the use, gradually that people, place, or thing becomes less powerful.
Yes.
When it comes especially to nicotine, even more than the other substances, The other set of triggers, the halt triggers as well as other ones, we refer to as stress triggers. And because stresses are unavoidable in life, they tend to last and have power for a much longer period of time than the cue triggers. Again, getting back to the basic science of it, these two kinds of triggers, the cue and the stress, light up different areas of the brain, and there are different neurotransmitters involved with them. From a clinical point of view, it still sets off the same sequence, which you see beneath the word trigger. Now, in the Beck diagram, it was a straight line where, in his view, always sets off an automatic thought. An automatic thought is something like, boy, a cigarette would really taste good now. Very, very quick, superficial thought, and in Beck's view, that thought always precedes the craving. But what my patients have told me is no, sometimes the trigger goes right to a craving with no thought intervening. So the trigger can set off either one, but whichever one is set off, it intensifies the other. So if you have a craving, that gives you more intense thoughts. If you have a thought, that gives you more cravings. And that step proceeds to what we call a stress relieving or pleasure enhancing belief, which is that whatever you're doing, whether it's something that's stressful, you think, well, I can't stand this stress. I need to smoke a cigarette or use a vape to relieve this feeling of anger or tension. Or I'm having such a good time, but I can have a much better time relaxing if I have a cigarette or use a vape. That fairly deeply rooted cognition, which is why we call it a belief, if it's allowed to intensify, leads to what we call a permission-giving rationalization, which is a very, again, superficial thought, which is something like, I'll only take one, or I'll only do this while I'm vacationing at the beach. And that very superficial thought, which I liken to the latch on a gate, allows the gate to be open and the person actually use for the first time. Initial use can be limited, or especially people who, with a addiction physiology rather than addiction psychology, find that rather than relieving the desire to use, it leads to an intensification of the desire, and that's what progresses to out of control use. So I have moved down the sequence, but what I didn't do was mention the top item, which is not always the case. I put that there because some people go out of their way to expose themselves to a trigger, and there's a certain kind of thinking that that's characterized, such as I'll go back to a place where I used to smoke or vape, but I don't think it will bother me to have people smoking or vaping around them. And this is something that people typically will do very early in recovery, when in fact they're much more vulnerable than they realize, and that rationalization leads them to actually take the step of going to that place and using. Another example would be to go to your convenience store where you've always bought your cigarettes and tell yourself, I'm only going in there to get a lottery ticket. And then when you're in there, see the cigarette packs so prominently displayed at the cash register and go ahead and use. So I wanted to mention that that's something that's not inevitably there, but it happens enough that it ought to be put into the sequence.
Yeah, I think some of the important things that I've learned from patients over the years is um, that sometimes a relapse feels like it happens in an instant. One minute I'm walking around and I'm fine, and the next minute I pick up that cigarette. So just kind of a re-emphasis on the fact that using a diagram like this helps really slow down um, thinking about how do I go from I've told myself, I've made an agreement with myself, and I'm continuing, I'm not using any nicotine, to then all of a sudden I'm smoking or vaping. So it slows down that process to kind of get an idea and insight into how that happens. And I think with the setup rationalization behavior, someone can actually stay there in that place with a rationalization and behavior that is risky for a while. And in fact, so someone may be able to go to that like local, uh, you know, little corner store where they used to buy cigarettes and kind of make their way there on a regular basis, not having bought cigarettes, during that time. But then all of a sudden, there's a trigger that happens. There's a stress relieving belief. They're having a bad day, they're feeling sad, or that something has happened that's really created stress in their lives. And now that they've been going to this place, they haven't created that distance. They're much more likely to be vulnerable for that, for the rest of this sequence to happen. So I think that is an important piece for folks to remember. And then at the bottom of the sequence in the permission giving rationalization, and I loved your latch on the gate, because I always think about the permission giving rationalization. It's the last thought that I have when I'm doing this internal tug of war. No, I shouldn't pick up, but I really want to smoke a cigarette, but I really shouldn't because I know it's not good for me. But okay, it's just this one time, and then I'm not going to smoke anymore. I just need to get through this next hour and then I'm done. It's that last thought that pushes me over the edge to get me to pick up, that
Mm-hmm.
makes me think, okay, this time it's going to be different and I'll be able to stop.
Right. I also wanted to mention that I explained this sequence from the top down, but
Hmm.
work with patients, we often work from the bottom up. Because remember, I talked about the insight that people get and the awareness that this is a process that develops over time. So we would typically have people come in, for example, and say, I was doing perfectly well. I was driving home from work. And then the next thing I know, I was passing the gas station where I get my cigarettes, and I just turned in and I bought a pack of cigarettes without thinking about it, and I started smoking. And what we'll do with people is we'll say, okay, let's start with that cigarette that you smoked. What were you thinking right before you smoked that cigarette? What was going through your mind? And that's when we usually pick up the permission-giving rationalization. But we keep, so to speak, rolling the tape backwards and saying, what happened before that? What happened before that? And we often discover that between that well before they pulled into that gas station, a series of events had occurred in their life that created just enough tension, just enough discomfort, psychological discomfort, that they, even though they were not clearly aware of it, it led to the use. But if you go back and review with them what happened before you turned into the store, what happened when you got into your car before that, what happened when you left work, what happened at work, that's when you get this increased awareness where instead of the tunnel vision of I was doing fine and then next thing I knew I was smoking, you get this broadening of awareness, and they start becoming aware of the different steps in this process, which the goal of that is to make people aware of the earlier steps so that they can intervene at that point and be aware that they're vulnerable, that they did have a particularly tense day at work, and they were feeling angry or disturbed in some way, so that the next time that happens and they're feeling that way, to the extent they're conscious of it, they'd be less likely to give in to these automatic thoughts and beliefs and not make that turn into the gas station.
Yeah, you really kind of made me just in listening to you talk about that. I think a lot of times from our patients and over the years, not just at Triple Track, but in other, in other places that I've worked, most people, when we first start to talk about this, most folks have like an I don't know response. And I think that is really, really normal because we don't usually walk around, most of us, being incredibly mindful of what we're experiencing and what is motivating us. We have phones, we have computers, family, kids, television, radio, work, all of these sort of distractions that keep us focused on the outward. And really what we're asking our patients to do is turn their focus inward. So this is such a great tool for practicing that one does not have to relapse in order to use. I think that is incredibly important. Well, sometimes we talk about this without ever getting to the initial use. A lot of folks can identify, okay, this is where I got to. I got to the stress relieving place, but I left that corner store and I went home. So the first piece is it really does create, as you said, this opportunity to be mindful, but it's very normal for most folks to, on their own in the beginning, feel like I just can't sense that, I'm not in touch with that, and I don't know. So I did want to mention it's so helpful to have somebody to talk to about this, especially in the beginning. Just trying to figure it out, on your own is not as helpful as having, a friend or a sponsor or a therapist or group that you can really process some of these thoughts and experiences with. All right, well, thanks everyone for tuning in and being here with us today. We'll look forward to continuing to do these. In the meantime, if you have any questions or you have a concern yourself or about someone you love related to smoking, vaping, or use of nicotine, you can go to tripletrack.com to reach out to Dr. Kolodner or myself. We would be very happy to talk to you and answer any questions. And otherwise, we will look forward to seeing you at the next one.